record this. All right, so we'll be going over chapter 35 today, Obstetrics and Neonatal Care. This is a pretty long chapter. I'm gonna try and pick out things and everything else, because if I don't want to load everybody up, I don't want to load their head full of stuff, because we have many more pediatrics that we'll be doing in the next couple of weeks until we finish out. So, or special populations until we finish out. So I'm gonna try not to hurt anybody's head today. Keep it as good as we can. All right. National EMS education standards and competencies here. And on to our introduction. All right. So you see up here, it says most births are uneventful and require little to no medical intervention beyond basic interventions such as suctioning, drying, and warming the baby. Others may be life-threatening to both woman and baby. And when the differences is that as we start to look through this, you got to think the human body is now compensating for the mother who's going to be with the child, and it's going to cause a lot of different body functions to operate on a different level. And homeostasis is going to be on a completely different operating level than what it was before. So it's going to react differently to illness and injury. And we're going to see that as we start to go through. So arriving at the scene of a woman in labor can cause all sorts of anxiety and fear on the part of both you as the AMT and the expecting parents that are there. Parents usually expect to deliver their child in a controlled setting, such as a hospital delivery room. So you can imagine how amped up everybody's going to be if they got to have their kid in an ambulance or in the back of a car or in a home or in a bathtub that's, with no doula there or anything else, no midwife there. So the birthing process usually requires little help from the healthcare provider, only pretty much supportive care of the pregnant woman and the newborn itself. Yeah. So there's the anatomy and physiology there. The female reproductive system is going to include the ovaries, the fallopian tubes, uterus, cervix, vagina, and the breast. So if fertilization does not occur, the lining of the uterus, it sheds during menstruation. That's when you have that. The female external genitalia usually, or the external genitalia include the vulva, the labia, which you can't see any of that in this picture. The labia minora, the clitoris, the prepuce, the labia majora, and the mons pubis. Why don't they have a good picture here of that? That would have been very much so helpful. All right. So gestation. The gestation is going to refer to the process of fetal development following fertilization of the egg. Following fertilization of the egg. That's gestation. So the fertilized egg is called the zygote, and it moves through the fallopian tubes towards the uterus. In the also in the 10th week and beyond, it's referred to as a fetus. So this figure here, it shows fertilization and implantation of the embryo. So you can see there, the umbilical cord connects to the placenta, connects the placenta to the fetus via the fetal umbilicus. The amniotic sac is a membranous sac that fills with amniotic fluid to protect and cushion the developing fetus. And during labor, when the fetus descends into the birth canal, the pressure on the amniotic sac causes it to rupture. Premature rupture of the membrane, the amniotic sac ruptures before the labor occurs. So premature rupture of the membrane is going to be the amniotic sac when it ruptures before the labor actually occurs. Gestation period is the time it takes the infant to develop in utero. So the 40 weeks you see there divided into 3 trimesters. Fetal heart tones can be audible by 17 through 20 weeks. Somebody trying to hit me up on Discord, I guess. I can't see it. It doesn't pop up for me. So the female and the male genitalia may be distinguished by ultrasonography at week 18. 18. Right. So a newborn is a recently born newborn is a recently born baby and is generally considered a newborn for the first few hours of its life. I know people bring them home and everything, they still call them newborns, but it's only considered a newborn for the first few hours of its life in all actuality. During the first 28 weeks of life, a baby is considered to be a neonate. So after that first few hours, it'll be a neonate. And then you can see there that between the ages of 1 month and 1 year, it's going to be referred to as an infant. So normal maternal changes of pregnancy. So one big thing to remember here, that's a good one to remember, is the total blood volume increases by about 50% by weeks 40 or by 40 weeks, and the red blood cells increase in number by about 30%. Those are pretty significant numbers. 50%. All right, that's a pretty significant amount. Cardiac output increases by 30 to 50% more than pre-pregnancy levels. And then in the second and third trimesters of pregnancy, the gravid uterus may compress the woman's inferior vena cava when she lies supine also. So, and that causes issues as well. Those are the three things that I want you to take with you when you're thinking about that. You know, how blood loss, when we're starting to talk about blood loss, when we're starting to talk about cardiac output, and then also if you have a female patient or a female patient, if you have a pregnant patient, which is going to be a female patient, most likely, maybe that faints, that's something to think about, you know, depending on how they're sitting. All right, so that increase of red blood cells, you can see there's going to be a more of a need for iron. So the pregnant woman often experiences gastrointestinal complaints at some time during their pregnancy also. And then you can see what that's followed up by there, decreased gastrointestinal function. So you can see there, vaginal bleeding is one of the common early pregnancy emergencies. It can be a sign of several different types of conditions that range from benign all the way to life-threatening. So it's always good to take note and to make sure that there's follow-up. So most spontaneous abortions occur during the first trimester before the placenta is fully mature. So an elective abortion is brought about intentionally, okay? And it's saying here, you know, you have to remain dispassionate and professional, regardless of your personal convictions of, you know, pro-life or pro-choice. So you have to treat a patient. We're there to treat the patients. Be an advocate. So a lot of times these threatening abortions, or these the threat of abortion, or a pending abortion, is, whether it be spontaneous or what have you, there's a lot of pain involved. So a lot of times there's a lot of cramping, a lot of pain, and a lot of mental trauma as well involved with this. So just something to take note. And also they can be pretty messy as well. So if it's an imminent abortion, it can't be prevented. You got to maintain blood pressure. So, and just remember, like we just talked about, there's 50% more blood circulating at this point, depending on what stage we're in. But we're getting it. So this one gets a little more into the numbers. 250 milliliter bolus of normal saline to maintain a blood pressure greater than 80 systolic. 80 millimeters of mercury systolic. And then also you see here 100% supplemental oxygen via non-rebreather mask, and then provide that emotional support for those patients. So incomplete abortions, there's going to be definite bleeding. It's going to be present, and it's going to be continuous. You just got to be on high alert for symptoms of shock. Make sure you get your IV line started, and you start running those boluses as soon as you can if you start to get ahead of the curve. So a complete abortion has occurred when all the products of conception have been expelled. That's between partial and complete. Ectopic pregnancies, implantation and growth of the embryo outside of the uterus. The woman usually feels lower abdominal pain and cramping. It can also be a life-threatening emergency, and the embryo will not survive, and it must be removed surgically to save the woman. So the bleeding that I was talking about, it may be internal or external, and it may be scant or it could be quite profuse, depending on what's going on. So, you know, there's no open, or there's no textbook show. So any detachment of the ovum or embryo from the uterine wall will result in bleeding on the third trimester, and this is during the third trimester. So at this stage, vaginal bleeding is a serious sign. Okay, so you got a couple major causes of substantial hemorrhage before the delivery are gonna be the Abruptio Placenta and Placenta Previa. Who remembers the difference between those? Does anybody remember? Well, other than I just showed you the answer. Does anybody remember right offhand? Placenta Previa and Abruptio Placenta. Somewhat. Right. So abruptio placenta refers to the premature separation of a normally implanted placenta. There's a couple of differences in there. So you see where the hemorrhage is, you can see where it's done, and you can have a partial. So my wife, when she was pregnant with my son, she actually had a partial abruptio placenta, and really all that they could do was bed rest. And if you're one of the things is you got to think about when we're talking about, let's go back to that because that did not explain. So one of the things is like you can see here it did explain. I just skipped it, I guess. Nope. So, yeah, there it is. So this is the big difference between Abruptio Placenta. So Abruptio Placenta, the placenta is in the normal spot. It's in the normal place. And you can have a partial or you can have a full Abruptio Placenta. But there's where the hemorrhaging is at there. The placenta is in the normal place. If you have a Previa Placenta or a Placenta Previa, then this is what you're looking at. The placenta will not be in the correct place. You can see here. That is not that. It's doing it to me again. Yeah. So previa, pre, meaning before. It's before. So you got the canal, then the placenta, because it's previa, it's pre. Then you got the fetus. And so placenta previa, before. Now, the big thing or the big difference with this is going to be some of the symptoms that you're going to see, that you're going to possibly see, or that the patient's going to experience. Okay. Does anybody know right offhand what the symptom differences are going to be? Because you're not going to be able to look at the patient and know what's going on. It's going to be based on your assessment of what may actually be occurring. So with Previa, this is the biggest thing. Right here. Painless vaginal bleeding. Whereas the other, Abruptio, is going to be painful. All right, so some hypertensive disorders. Chronic hypertension could be an issue. There we go. And then chronic hypertension can be a blood pressure that's equal to or greater than 130/80. Mine stays that way. So any diastolic that's over 110 can place that patient in a stroke category or some other cardiovascular danger. So something to be mindful of when you're doing your assessments. Gestational hypertension after the 20th week. And then preeclampsia is when that develops. Preeclampsia. Gestational hypertension. So postpartum eclampsia, it's usually present within the first 24 hours after delivery, but it may occur as late as 4 weeks following the birth too. So it's good to, when you're asking about that recent past medical history, which I'm I'm sure there may be some other clues that draw your conclusion that they may have given birth recently, but just in case, like a baby being around. All right, so isoimmunization. So Rh factor is a protein found on red blood cells of most people. When a woman who is Rh negative becomes pregnant by a man who has the Rh factor and the fetus inherits this factor, fetal blood can pass into the woman's circulation and produce a maternal antibody or an isoimmunization to the factor. It's normally not a factor in first pregnancies. It is normally not a factor in first pregnancies. I get tired of looking up at this camera. Gotta find some other place to put that thing. Hold 1 second. Sorry, I had to get that. I wasn't comfortable with having to stare up at the camera the entire time. It was getting old. I'll make some adjustments. All right, much better. All right, so moving on from that. So in subsequent pregnancies, the antibody will aggressively cross the placental barrier to attack the fetal red blood cells, which the woman's body identifies as foreign proteins. The attack can result in death for the fetus or cause hemolytic diseases. Okay, you see that there for still talking about Rh sensitization or isoimmunization. And in that case, they do have, there are some things that they try to do to prevent that, some types of medications, things like that, that they try to do to prevent that. All right, so gestational diabetes, the inability to process carbohydrates during pregnancy. The patient, they can be asymptomatic or may exhibit the same signs observed in patients with diabetes mellitus, like polyuria, polydipsia, and polyphagia. So you can see there, the treatment consists of a diet control and oral hypoglycemic medications. So patients with diabetes may experience wildly fluctuating blood glucose levels during that time. So as you can see here, if this is something that happens, the fetus may grow to a larger than average size and may not fit through the birth canal. So it can actually grow to a abnormal size at that point, just because of gestational diabetes. Hyperemesis graviton. What do you think that means? Hyperemesis graviton. What do we generally call that? Sounds nasty. We generally call it like morning sickness. That's what we generally call that, morning sickness. But it's hyperemesis, so now they can't keep anything down, and because of that, they become malnutrition, and that becomes a very bad problem. Yeah. So this could be anything upwards persistent vomiting, which could be in upwards of 3 or 4 times a day. Them kids. So you see here, premature rupture of the membranes. The amniotic sac ruptures or opens more than an hour before labor. The pregnancy is not yet at term, and there's risk for infection when that happens. So the biggest thing to do at that point, or what we can do, is provide emotional support and transport. Support and transport. So there are some special considerations when we're talking about trauma in pregnancy. So severe hemorrhaging being one of them. Different types of anatomic changes to the body. It can cause different types of injuries. The redistribution of blood. So anything that involves substantial maternal bleeding will threaten the life of the fetus. So airway, breathing, circulate, your A, B, C, D, E's, right? It's going to be your highest priorities in this event. So the examination of an injured pregnant woman may reveal an abnormal fetal position, an easily palpated fetus, inability to palpate the top of the uterus, or vaginal bleeding can all occur at that time. So a pregnant woman should be transported to the hospital on her left side and with her right hip elevated about 6 inches. Okay. And then you can see there, airway, oxygen, ventilation, circulation, IV fluids, and then transport considerations, where you're going to take them, know where you're going to take. So do be mindful of cultural considerations. And then if they have any, if they do have any differences other than what you may be used to, then you want to try and honor those requests as much as possible from those patients. So teenage pregnancies, pregnant teenagers may or may not know that they are pregnant. A lot of times, if you separate them, if they, other than if they obviously look pregnant, but a lot of times you can separate them from the parents or anybody else and kind of talk to them to ask those type of questions. If they're, if they've been sexually active, or do they feel like, or is there a possibility they could be pregnant? You may want to separate from the family while you have those type of discussions whenever you're getting that information from those teenagers. So some big takeaways from this: gravita. When you're calling that, or when you're documenting gravita, that's the number of times a woman has been pregnant, no matter if they survived, or no matter if they were birthed or they died or what have you. Gravita is the number of times in total that a woman has been pregnant. Prima gravita just means that it's the first and only time so far that the woman's been pregnant. So para is the number of times a pregnant woman's delivered a viable newborn. So gravida para, right? And then prima gravida, like I said, a woman who is pregnant for the first time. Prima para, a woman who has only had one delivery. Multigravida, 2 or more times, irrespective of the outcome. Or nullipara, a woman who has never delivered a viable newborn, although she may have been pregnant before. All right. And then also there's some others like multipara and grand multipara. A bunch of them. ABCDEs, very important. Like we talked about, if you do have somebody in trauma, spinal immobilization has to be done. You can see here in the picture how they've taken and actually put a blanket underneath the patient on the right side, so that to keep that patient, or to keep that issue from happening, like we're talking about, from the child leaning over onto the vena cava and causing a possible syncopal episode or a hypotensive episode. So there's some questions to ask. Length of gestation and estimated due date. The gravida and para, you'll get asked that by the hospital when you call in your report, more than likely. If you ever have to do this. Fun. All right, we'll look through a little bit of this. We're not going to go all the way. So important numbers to learn. Contractions are 1 to 2 minutes apart and last for 30 to 60 seconds at full term. So that full term delivery it may be imminent, or it could be very well could be an issue, or this could be the issue. So there's and then on the other end of the spectrum is the Braxton Hicks. We talked about third trimester bleeding, what to do with that. Ectopic pregnancy, severe pain, hypovolemic shock. So treatment is focused on supporting the ABCs, IVs, all that good stuff. Treat for shock, IVs, very good things to get into. Preeclampsia, also same thing. So swelling in the hands, face, and feet. Preeclampsia also, we're talking about that. You'll notice it'll have that hypertensive reaction. or they will be hypertensive. They will be hypertensive. Again, ABCs, IVs, treat for shock. You can take care of it. Ain't no big thing. You got to call for the helicopter or paramedic. There's been plenty of EMTs with the little baby rattler pins or whatever they have. All right, so before we get into this, let's take a quick break. Before we get into this, it's 15 slides in, so we'll take a quick break.
See you later, not having Wi-Fi when you want it. To a phone plan.
I don't know why they put these commercials on here.
Hello, Google Fi. A phone plan that can. Grammarly Business is an AI-powered writing assistant, enabling teams around the world.
They have ruined YouTube. All right, so 10 minutes, and I'll see you. Rainbows. Awesome. Mercy. Okay. So we'll get in the stages of labor. So the onset of labor starts with contractions in the uterus. And then it says lightening refers to, or lightening refers to the movement of the baby moving down the pelvis prior to the birth. So it's starting to move into position, get ready to go. Lock, stock, ready to rock. So there are 3 stages of labor. The first stage begins with the onset of contractions and ends when the cervix is fully effaced or effaced and dilated. The second stage of labor is from the point of full cervical effacement and dilation until the fetus is delivered. And then the third stage of labor begins with the delivery of the newborn and ends with the delivery of the placenta. 3 stages. So a few things to remember. Oxygen is definitely going to be needed. Prep your equipment. Because once you get started, it's gonna be ongoing, or it's gonna be on. And then don't attempt to hold the pregnant woman's legs together to try and stop the birth. That it doesn't really work like that. So you need to help and support the newborn as it's being born. So you can see here patient positioning. You can see a good picture of it there. And then you want to track the progression of delivery closely at all times. So you see here, place towels and sheets on the floor around the delivery area to help soak up any type of amniotic fluid and other fluids that may be coming out as well. And then it's supposed to be a sterile procedure. So just like how we talked about, you open things. When you open an OB kit, it's going to have surgical gloves in there and everything else. It is a it's supposed to be, like I said, a sterile procedure. So, you know, as you put the gloves on, you can't touch you're not supposed to touch the outside. It's supposed to be clean. You're not supposed to touch the outsides. And when you open up the box, you fold it out. You know, you open it, you fold it out. Everything is done to where the outside of it will remain sterile. And then when you remove anything, it's got to be done that way too. That's including sweat, everything else that may come off of you. If you sweat on it, you've contaminated a sterile field. So in the kit, you have the iodine, or you got the chlorhexidine scrub. And a lot of times it looks like a scrubber, or sometimes it looks like a scrubber. You pop it and then you can rub it all over your fingers and all that. Or it may be something to where you can take maybe a piece of cloth that you rub on it, or a squirt. It'll like a container that you squirt on, and then you got to clean up with it. And then you create your own sterile field using the sheets and towels out of the kit to wrap around the patient and do the area, as you can see in the picture here. So one person at the head to soothe the patient. Always look for crowning. What is crowning? Can you explain to me what crowning is? Anybody tell me what crowning is? So yeah, it's whenever the vaginal wall or the outside of the vagina starts to open up, and then the top of the baby's head is there, or you'll start to see start to bulge out to make way for the head to come out. So the top of the baby's head is probably the best way to describe it. That's right. And do not allow for abrupt delivery. That can happen. What you want to do to prevent that is you want to be able to take and, sorry, I got to move some stuff around. You want to be able to take and hold gentle pressure. Don't push, but just hold gentle pressure as you're letting out. That way you're not, just making sure your hand's there so it doesn't pop out on you, and then you end up dropping the baby or what have you, which is, dropping the baby is usually never good. It's usually not a good thing to do. So in between contractions, encourage deep breathing, resting. Wrap the newborn up. If you can still remember how to wrap, but wrap it up as best you can to keep the baby warm, because they don't have really good thermal regulation straight out of the birthing canal. And then it also says here to keep the newborn at the same level as the woman's vagina until the umbilical cord is cut. Makes sense, right? Because of the blood flow. And there's a little bit of explanation to APGAR scores. Just read over that. Okay. Cutting the umbilical cord. So one of the important things to remember is to tie or clamp it off in 2 different places, and then also waiting for the pulsating to stop before you start tying and clamping and cutting. Postpartum care. So after the delivery of the placenta and before transport, place a sterile pad or a sanitary napkin over the vagina and straighten the woman's legs out. Slow postpartum bleeding may be gently massaging the uterine fundus with a firm circular kneading motion. You can see that he's doing that here, or he or she is doing that here for the patient in the picture. And then close monitoring on your way in. Be sure also to record that time of birth in your patient care report. Get you some vital signs. You see there, postpartum hemorrhaging, some points. So if it exceeds 1 pint or 500 mLs during the first 24 hours after giving birth, it'd be pretty deal in situation. If the placenta hasn't delivered within 30 minutes, so again, you want to make sure that you place a sterile pad or a sanitary napkin over the woman's vagina to collect any blood. Manage external bleeding with perineal tears with firm pressure, and the bleeding should stop. So labor that begins after the 20th week, but before the 37th week is considered preterm. The threat to the unborn fetus is going to be a premature birth. That's going to be the threat to there. In the field, you can see here, best treatment option. So bolus of isotonic crystalloid solutions. Isotonic crystalloid solutions. See the size differences there. All right, uterine rupture. So if they have a scar on the uterus, then it's more likely that that it can happen again, or that a rupture can happen because it's already a weak spot, right? That's why that's saying that. You can see here, very painful contractions, very strong painful contractions. And then the substantial bleeding may or may not be obvious. Merconium staining. So in the cases of fetal distress, so it could expel meconium into the amniotic fluid. Who knows what meconium is? What is meconium? Who can tell me what that is? Yep. Fetus poop. That's pretty much it. Yep. It's when the baby or the fetus defecates inside of the womb or inside of the amniotic sac. If there's a yellowish tint to the amniotic fluid, it could suggest a meconium issue. Green and black color, especially the presence. So that first poop, if you remember, if any of you have had kids before and you remember the first poop, how black and tarry it was, that's what it's talking about. That could be expelled into the amniotic sac. So multiple gestations, keep a spare OB kit in your truck. One of the biggest things is talking about here, the meconium still. One of the biggest things is if it aspirates that, it can cause severe problems. Mostly infectious type of problems or pneumonia. So you see here for multiple gestations, you just repeat what you did on the first delivery. So baby's got a big head, cephalopelvic disproportion. So it may need a cesarean to be required to prevent maternal or fetal distress. At that point, we just have that support, get them to the hospital. So complications of labor and delivery can result in death of the fetus. Don't attempt to resuscitate an obviously dead newborn, kind of like with, obviously dead adults. We're not going to attempt to resuscitate if there's no obvious signs of life or something that's not going to be in line with life. If they're having issues, it's not in line with life. So just make sure that you're paying attention to that. So on the other hand, if there's been a complication during the birthing process, such as a cardiac arrest, then that is something. If it happened while we were delivering, then that is something that we can try to intervene on. Amniotic fluid and embolisms. Says is extremely rare. So it could be on the test. Breech presentations. When they're rear end first, right? Feet first, rear end first. And that's most likely when you're going to see other types of presentations also. That can be very distressing on the child as well. And on mom. There's the limb presentation. You see, because baby's breached. But you can also have an arm or a leg or what have you. At that point, you're not trying to push it back in or anything else. Just cover it with a sterile towel and try to get to the hospital as quickly as possible. It's going to have to be done by surgery. Shoulder dystocia. So there is some other ways to try to fit that baby through there, through the canal, with the shoulder dystocia. But if it can't get past the symphysis pubis or the pubic symphysis there, so the pubic symphysis it actually splits. So if you remember the pelvis, and when you're looking at the pelvis, you had in the open area, there is a bit of like a suture, almost like a suture between where the pelvis connects. It usually what breaks when you have an open book fracture. It's one of the pieces that breaks. So during birth, it actually separates. And it separates to make the birth canal wider. If for some reason it can't get through there, you have problems like shoulder dystocia or anything like that, then at that point it may need to be surgically remedied. Time with having me in his pocket. So like it says here, you can try the McRoberts maneuver, and you're trying to get that baby over by rocking the shoulder through there. Nuchal cord. So if it's wrapped around, the umbilical cord gets wrapped around the baby's neck. Some things you do, you may need to place your hand in there, make a tent like over the baby's face, and try to undo that cord if you can. In the birth canal, you may actually have to operate within the birth canal. Keep the baby from asphyxiating. You can see here, slip your finger and then gently attempt to slip it over the newborn's shoulder and head. Prolapsed umbilical cord, unlike when you have a limb presentation, you may have something like the umbilical cord may show. And at that point, it can kind of kink. And then what happens if it kinks up, then the blood supply is going to be interrupted. That's going to the newborn as well. So you do want to prevent them from compressing the umbilical cord or pushing and compressing. So place the knee chest position, as you can see here in this picture. Uterine inversion. When the placenta fails to detach properly and adheres to the uterine wall when it's expelled, can result in placing excessive pressure on the uterus during fundal massage or from exerting excess traction on the umbilical cord to hasten delivery of the placenta. So somebody pulling on it. Guessing what they're saying? So you get one attempt at replacement by using the palm and try and push it back inside the body. One attempt. After that, don't try to attempt it again. Never use your fingers. Try to replace a prolapsed uterus. 100% oxygen. Treat for shock. Start two IV lines. Large bore IVs. Pulmonary embolism. We know what that is. We've talked about that on several occasions. Spina bifida. Portion of the spine or spinal cord or the meninges may protrude outside of the vertebra. And this is for newborn complications. All right, neonatal resuscitation in utero, a fetus receives its oxygen from the placenta itself. As the fetus delivered, a rapid series of events needs to occur to enable the newborn to breathe, called fetal transition. Following fetal transition, the neonate breathes and oxygenates his or her own blood. That's why after the birth, that they do the slapping of the booty for the baby, and the baby cries or will tickle their feet. The baby will start crying, and that's gonna be what starts that transition. And there's a good picture of fetal circulation there. So the belly button, right? Just point of reference. Belly button. All right, there's a list of causes of delayed transition in newborns. So after delivery, the cause for the first tick that you see there, after delivery, the cause is usually a result of an airway or breathing problem. And then you can see the clinical findings of fetal distress over here, or down below that. So the initial steps are going to be aimed at stimulating the newborn to begin spontaneous effective breathing. So most of the time, the cardiac arrest for a newborn is as a result of respiratory. Most of the time, some sort of respiratory distress. So we want to make sure that we're definitely paying attention to those ABCs, what's going on, and making sure that we're taking the vital signs, or we're getting the correct vitals or accurate vitals from the newborn or the neonate. So skin color being a big indicator. If they're blue, that's not good, right? But that's also why we learn that APGAR score, and that's going to help us. 1 minute and then 5 minutes. 1 minute after birth, or up to 1 minute after birth, and then after 5 minutes, we'll do another APGAR score. And that kind of lets us know what's going on if the baby's properly perfusing. So make sure you keep the baby warm. That's going to be a big deal. And there's an APGAR score table in your book, and it's going to be labeled 35-4. 35-4. So there's the algorithm for neonate resuscitation. So compressions below 60 beats a minute. So if you're getting a heart rate of below 60 beats a minute, you need to start compressions, right? So it's saying here, consider intubation, which means we should already have a paramedic come on scene. You should have called for a paramedic if it was imminent possibility of birth. So it's also talking about there administering epinephrine IV. And then consider hypovolemia and pneumothorax. So it's almost, if you remember from your, doing CPR-AD, or not so much CPR-AD, but ALS, ACLS, if you ever get a chance to do ACLS, some of the things you'll learn is your H's and T's. And it's the same thing here. You start going through your H's and T's, is what it's called. Look it up. It's something that can be very helpful during cardiac arrest. H's and T's. Free flow of oxygen. It says there you can use a newborn nose kit, or you can take and you can pop this line off. Yeah, you can pop this line off right here and just hold it under their nose and mouth, or near their nose and mouth, in case you have an adult one or what have you that may cover their whole face. So bag valve mask and ventilation. It's going to be a very small bulb on there, because they don't need much. They take as much air as what you hold in your mouth. Not much air. So you definitely don't want to get too overzealous with it, because you don't want to blow a lung. So remember, it's not that much air it takes. So you're looking for a pulse rate of 100 beats a minute, somewhere around there. And this is one of those situations too that talks about the sniffing position here. You may want to put a towel underneath the baby's shoulders to create that. So the thumb encirculating, thumb or the hand encapsulating, thumb encirclement, whatever they call it now, the thumb technique. And then also the two fingers between the xiphoid process, imaginary line between the nipples. So imaginary line between the nipples, go there, you can pump it out. And you can also do this, with the baby in your hand. You can hold the baby in your hand as well. So if you're using BVM, about every third compression, you want to do your ventilation. About every third compression. And like we talked about before, adequate ventilation. So most of the time, it being respiratory distress, the cause of a lot of cardiac issues, or a lot of cardiac arrest issues, goes into a respiratory arrest for neonates. So most of the time, respiratory is the issue with neonates and children. Vascular access. You can see here, you can bet it looks like it's going to be hard to do, and they may take a smaller catheter, 20, a 22 or a 24 is what you may have to use to keep from blowing a vein out so bad. But antecubital space there, I've seen people stick them in the forehead, so on and so forth. We don't really have UVCs that we carry, or that we do. So if you have a child that's apneic, then they're not responding to PPV, you may have an issue. You just gotta keep at it with the oxygen, PPV, and compressions, and also that epi. Respiratory support, as you can see here, is going to be pretty important. Bradycardia, if they start to brady down below 60 beats a minute, remember those compressions. Also, again, respiratory distress may be an issue for maybe causing that bradycardia as well. So make sure that we're getting good oxygen. And then also is saying, if you see here, intracranial pressure in older children can result in bradycardia, and that's because of the pressure that's put onto those parts of the brain, right? Causes issues. Hypoglycemia, anything less than 45. So a newborn can be asymptomatic until they reach a level less than 20. Yeah. And just remember what we talked about during class is the difference between taking a CBG with using capillary blood versus venous blood. There's almost a 20% difference in the numbers there, which can be pretty significant depending on what we're trying to get a field diagnosis for. Hypovolemia, shock they'll appear pale and have weak pulses. At that point, again, effective ventilation, chest compressions, and then also cardiac measure, epinephrine, stuff like that. So with an adult, 20 milliliters per kg with an adult. With a child, it's going to be cut in half, or not with a child, but with a newborn, it's going to be cut in half. 10 milliliters per kg for a newborn. So 20 milliliters per kg for an adult, 10 milliliters per kg for newborn. All right, and I think that's going to be about it for this. This chapter here is one that you really need to read and study, and then take the test on. Something that I did do is that if you have not finished your module test or any of your other tests like that, you need to get in there and finish it. And I opened them up until Wednesday. After Wednesday, I have to shut them down so that I can get everything graded. Because right now, if I were to grade them, there'd be some people that have a litany of zeros in there, and you would not be passing the class. So I need people to get in there before I start having to settle in the zeros or anything like that. So let's make sure that before Wednesday, we're getting in there and we're tackling it and knocking this out, because the tests from here are only going to get a little harder because it's pediatrics and newborns and geriatrics. It's things that are out of the ordinary, special populations until the end of class. We're right here near the end. We got a month. We got 1 month. And so long as we get really good participation, then we can have the class and what have you. I don't like giving the lecture to half the class because then everybody else doesn't get it. And if we have people that aren't understanding it, then they're not speaking up right then. And in these areas, like I said earlier, 2 people that I spoke to just recently said that a huge part of their test were special populations. So make sure we're paying attention here for that. Okay. Moving forward to get to today's test, your code is going to be 3322. Your code is 3322. So doing the extra little quizzes and things like that, that's going to help you with your understanding of the material. The book quizzes, it actually helps you with your understanding of the material. All right, so the test out is 3322. I have updated the attendance. The only one I haven't updated was today's. So as of right now, the attendance is updated, except for today's. But after Wednesday, I'll have to calculate any zeros that are put in there. And the module test, if you don't get a drop grade, you get one drop grade per module for each module. You get one drop grade. But module test, the big test, you don't get a drop for those. There is no drop for that. If you fail it, you fail. And those are, that's a large part of your grade. So make sure you complete that out. Okay. If you do have any issues, please give me a call or give me a message. Send me a message on Navigate. Send me a message on Navigate, and I'll get in there and take a look and figure out what's going on. I tried to get in there and make any changes, set anything lined up in the grade books or anything like that, and open up all others. There's a lot that are open. Also, there's a lot of tests that are open. If you have missed a test, look in your grades. If you see a tick mark in there, you missed a test, get in there and attempt it. Do that sooner rather than later. And then let me know if something's going on so I can make any type of adjustments or see what we can do. Okay. I get it. It may be quite a bit for a few people. Get them done. Let's just get them done. Let's knock them out and let's move on from there. All right. All right. Other than that, I'm gonna be getting off here and prepping for our next class. And I will see you on Wednesday in that case. All right. If you need me, you know where to get a hold of me. I'll be around. All right. Y'all have a good night. Be safe. Oh, also send me your days. I need your days. So send those to me as well. And I'll send something out in messaging. I need days. That's the only way for me to get you rides. All right. Talk to y'all later. Y'all be good. Bye.